Welcome to the last lecture for the semester. Holy cow, we are finally done. Can you believe it? That is, I think we have had 32 lectures this semester, so it's been quite a long time. Hope everybody's doing well. If you're out there, go ahead and type in the chat bar and tell me hello. Otherwise, I'm going to go ahead and get started with chapter 15. Okay, so let's go ahead and go to the PowerPoint. We're going to finish up psychological treatments today. We're going to talk a little bit about biological treatments, including drug therapy, psychosurgery, and electroconvulsive therapy. Okay, so let's go ahead and get started. Biological treatments. So, biological treatments capitalize on what we know about brain function. So, everything that we know about from chapter 2 is going to be part of the toolbox that is used by clinical psychologists to treat people who are suffering from psychological disorders. Okay, so treatments for psychological disorders in the early 1900s was mostly biological and reflected no real understanding of how the brain works. Treatments for psychological disorders at the turn of the 20th century included warm baths, wrapping people in wet towels, giving them insulin to make them go into insulin shock. There were all kind of crazy things, and none of those therapies were really based on science, and none of those therapies worked at all. Now, what we have now are newer forms of biological treatments, which are effective, not as good as we'd like, but they're pretty effective. And they're based on some general insights about brain functioning. Now, here are the things that you should remember from chapter 2. If you remember, brains secrete and respond to chemicals called neurotransmitters. So we can adjust the neurotransmitter functioning in the brain to help people suffering from psychological disorders. Brains generate and respond to electrical stimulation. So we can adjust the level of electrical stimulation in the brain to help people suffering from psychological disorders. And we know that brain functions are localized. So the brain is divided into many specific areas, each area responsible for a function. So some functions are being disrupted by abnormal brain areas. And so we can adjust these areas of the brain. Now, there are 3 different types of biological therapies based on these. There's drug therapies, electromagnetic therapies, and there's psychosurgeries. And each treatment is set to go with a specific disorder. So if you have this disorder, some treatments work better for some disorders than do others. Okay, good morning, Medina. Thanks for coming today. It's good to see you. Just talking about biological therapies, they're based on our knowledge of how the brain works. So biological therapies for clinical psych disorders can be adjusting the chemical functioning in the brain, adjusting the electrical function in the brain, or removing problematic areas of the brain. Okay, so let's talk a little bit about therapies. Now, the first concept you need to remember, and this was from chapter 2, we talked about agonist versus antagonist. Neurotransmitters work in your brain. If you look at this chart underneath here, Medina, you'll see this is a chart from chapter 2, and it shows you how neurotransmitters work at the synaptic level. If you remember what we suggested to you, action potentials are created by neurons. When the action potential travels down the length of the axon, when it gets to the end of the axon, it causes that axon to release neurotransmitting chemicals. Those are the neurotransmitters, right? Now, what clinical psychology uses is these drugs we'll call generally neuromodulators, and they're just modules that affect the synaptic functioning of neurotransmitters. There are 2 basic types of neuromodulating drugs. Some neuromodulating drugs multiply the effect of the neurotransmitter in the brain, and some of the neuromodulating drugs work against the neurotransmitter effects in the brain. So you have agonist or antagonist drugs. Good morning, Lewis. Thanks for coming. So there are different classes of antipsychotic drugs. There are drugs that help us treat people's anxiety levels. There are drugs that work on the hormone neurotransmitters related to depression and stabilizing of the mood. There are drugs that work as antipsychotics, and there are some drugs that work to stimulate areas of the brain. And so what psychotropic drugs do, what your psychotropic medical drugs do, is they moderate or mediate the functions of the neurotransmitters. They're either agonists or they're antagonists. Now, here's what you need to know about drug therapy. Again, I'm not a clinical psychologist, I'm not a medical doctor, so some people would say I am not an expert and I can't talk. Fine. But here's the deal. What we know about these neurotransmitting drugs is that they cause the correct behavioral effect. Nobody exactly really knows how dopamine is related to schizophrenia. We just know that if you give a schizophrenic person dopamine impairing drugs, their symptoms get better. We don't know exactly how serotonin is related to the modulation of mood. All we know is that if we give people who are depressed drugs that multiply their serotonin function, their mood gets better. So really, drug therapy is based on the idea that we know that these drugs have the desired behavioral effects. Okay, we do not know the exact chemical pathway by which psychosis or neurosis, anxiety, depression, we don't know specifically how these things are chemically created in the brain. We just know that these drugs have general effects which give us the desired behavioral outcomes. Does an SSRI like Zoloft cure depression? Nope, but it makes the symptoms go away for a while. Now, one of the other things you need to know is that here's even more complicated, an even more complicating factor. We know that neurotransmitters are responsible for multiple things in our brain. And so the drugs that you take can be used to treat multiple disorders. So I know that there are some people who take an antipsychotic as a mood stabilizer. I know that some people who take antipsychotics that are actually prescribed for their ADHD. And so some drugs, what you're going to find is some drugs are used for multiple psychological disorders, suggesting, in my opinion, how little we really know about the specific mechanisms, biological mechanisms that control these psychological disorders. Now, since neurotransmitter effects occur and vary in different parts of the brain, psychotropic drugs will always have unintended and potentially disrupting side effects on the function of the brain in other areas. So your entire brain uses dopamine, and it uses dopamine for lots of different things. If I give you a drug that decreases the functioning of the dopamine in your brain because I want to get rid of your schizophrenic hallucinations, that may work, but this drug is coursing systemically through your brain, so it's going to cause other things to happen as well. So keep in mind, we really don't know the biological mechanisms for psychological disorders. What we do is we give people drugs because they give us the desired behavioral effects. And these drugs that we use are not do not have a one-to-one correspondence with these disorders that we treat. And these drugs affect all of our brain's functioning, not just the functioning that we're interested in affecting. But drug therapy, I would argue, is the most popular, some would say the most effective way of treating psychological disorders. The success of psychotropic medication is not 100%, okay? Some of you out there may have already discovered this, or you may have friends that can tell you about this. There's a lot of experimentation that goes on with your clinical psychologist, trying to get the drug that affects you. And so they may try this drug for a while, and then they may try this drug for a while. Sometimes a drug will be effective for a while, then it'll effect will go away. Drug therapy, it's not great, but it's probably the best tool that we've got. Now, drug therapy actually was revolutionized in the late 50s with the invention of an antipsychotic medication called Thorazine. And this Thorazine was effective enough that it led to a mass deinstitutionalization in the United States because people who were hallucinating and being deluded, who needed to be kept in special places, were finally functioning well enough so that they could get out of the psychiatric institution. So Thorazine and drug therapy was a watershed moment in clinical psychology. That's odd. I'm not sure what happened to my PowerPoint. But, oh crap. What happened to my, okay. My PowerPoint's messed up, so I'm going to carry on. But one of the things that we do treat for bipolar behavior, we use mood stabilizing drugs like lithium. And see, this Depakote is also used for schizophrenia too. So one of the things that we do with bipolar disorders, we use mood stabilizing drugs. Typically, it's lithium. Lithium's a little bit dangerous. That is, the therapeutic dose is close to the toxic dose. That is, the dose that helps you is almost the same amount of the dose that can hurt you. And so doctors have to be careful. Typically, when you are diagnosed and given as bipolar and given lithium, what they'll do is they'll give you a small level of lithium, and then they move the level of lithium up carefully, stopping at the point at which it causes your moods to quit swinging so strongly. And so lithium is used to treat bipolar disorder. Now, if you remember from 2 days ago, I talked to you about the different diagnoses of bipolar. There's bipolar 1 and there's bipolar 2. Bipolar 1 is characterized by stronger manic periods than depressive periods. Remember, bipolar people have periods of mania and periods of depression. So people with bipolar, what you're going to find is their manic phases are stronger than their depression phases. People with bipolar 2, their depression phases are more pronounced than their manic phases. So typically with bipolar disorder, what we'll do is we'll give you the mood stabilizer like lithium, and then if you're bipolar 1, we'll add an antipsychotic, because a lot of times people's behavior and thoughts seem a little psychotic when they're in their manic phase. And if the person has type 2 bipolar, we will add an antidepressant as well. Now, the use of antidepressants is always tricky, and you have to, one of the things that we do know is while it doesn't specifically increase suicide in teens, we do know that the use of antidepressants is associated with an increase in suicidal thoughts in teenagers. And the first step to actually committing suicide is to begin to ideate, to talk about that. So what you're going to find is that there's usually a warning label on the bottle saying, especially for teenagers, if you're giving them this drug, you have to be careful with this drug. So lithium and a combination of lithium and either an antipsychotic or an antidepressant is used to treat bipolar disorder. Now, serotonin is implicated in depression. What we think is that people who suffer from depression for one reason or another are not producing enough serotonin, or the serotonin is not effective enough. We're not exactly sure the mechanism, but we know that when we give people drugs that multiply the amount of serotonin, or multiply the effect, magnify the effect of serotonin in their brain, their depressive symptoms go away. Now, if you look right here, as it says, 8% of 12 to 17-year-olds have had a major depressive episode. 8%, 1 out of 10 teenagers has had a depressive episode. Okay, depression is the common cold of psychological disorders. And I don't know if you know this, but suicide is the second leading cause of death in adolescence. All right, and so it's very important that we figure a way to treat depression. And if you look at this chart over here, what you're going to notice, as I suggested a couple of days ago, depression is more common in females than it is in males. Now, if you look over here, treating depression, there are two basic mechanisms by which we think these neuromodulating antidepressants work. You have MAOIs and SSRIs. An MAOI is a monoamine oxidase inhibitor. Monoamine oxidase is a neurotransmitter is not a neurotransmitter, excuse me, it's a molecule in your brain that metabolizes serotonin. It eats up serotonin. So after neurotransmitters are send their message in the synapse, some of them are taken back up into the terminal button of the presynaptic neuron into the axon. But some of the molecules just float around in the synapse and are cleaned up by this molecule called monoamine oxidase. And so monoamine oxidase inhibitors inhibit that monoamine oxidase, which allows the serotonin to remain in your synapse a little bit longer and send more messages and magnify its effect. We also have these things called SSRIs. Anybody ever heard of this? Selective serotonin reuptake inhibitor. So what this does is this prevents the serotonin from being sucked back into the presynaptic axon terminal button. Both of these mechanisms, not cleaning up the stray serotonin floating in your synapse or not letting the serotonin get sucked back up into the presynaptic terminal button, both of these, their end goal, their final outcome is that they magnify the amount of serotonin that's floating around in your synapses. So MAOIs and SSRIs both work by magnifying the functioning of the serotonin in your brain. Again, what I'll suggest to you is that antidepressant usage may be associated with increased suicidal ideation in teenagers. I'm sure you folks, well, maybe you have seen the commercials. I've seen the commercials. Whenever they talk about those antidepressants, they always have a warning at the end of the commercial suggesting that you need to be aware of suicidal ideation in teenagers who use these SSRI drugs. Now, the research doesn't necessarily suggest that the use of Zoloft causes teenagers to engage in suicide. As I said earlier, though, we know that the first step along the pathway to committing suicide is first having the ideation of committing suicide. And so clinical psychologists are kind of worried about this potential side effect that occurs in teenagers. Okay? Now, if you look down here at the bottom corner, I have the data from a very important study that wanted to look at the effectiveness of the different treatment methods for adolescent depression. This was the TAD study. And what they did was they compared cognitive behavioral therapy, which I told you about yesterday, with the use of an antidepressant or a combined usage of both cognitive behavioral therapy and the antidepressant. Okay, so the TAD study wanted to see which is more useful, drug therapy, cognitive behavioral therapy, or a mix of these therapies. And as I suggested to you, they compared it with people who weren't getting either of those treatments, a placebo group. Now, as you can see, the placebo group had an improvement in symptoms. the prognosis for some of these disorders is that they vary. They get better, they get worse. And what you're going to see is some psychological disorders will just get a little bit better on their own. And so what we want to make sure is that our therapy is better than what would have happened on its own. And you'll notice that the placebo shows a slight improvement in the symptoms over the course of this study. So over 12 weeks, the people who are getting drugs, their mood improved anyhow. But then if you compare the CBT, which is the cognitive behavioral therapy, versus the drug therapy versus the combined, what you're going to see is that Prozac, the use of an antidepressant, actually is about the same, maybe a little bit better than the use of cognitive behavioral therapy. The outcomes aren't that much better for Prozac than they are for just using cognitive behavioral therapy. However, if you combine the use of both of those, your outcomes get even a little bit better. Now, why is this chart important? Here's the thing. If you look at it, the use of CBT alone or Prozac alone, both of them, it's a coin toss. They're both equally effective in treating your psychological disorders. So, why does the insurance company prefer Prozac over CBT? Well, because Prozac can be given to you for dollars a day, okay, whereas cognitive behavioral therapy requires many $250 treatment meetings, interventions. And so what you're going to find is drug therapy is much more inexpensive than true psychotherapy. And what this chart shows you is that these therapies, drug therapy and non-drug therapy, are about the same. What I'm going to tell you is, like I said, your insurance company bases their choice of treatment on what saves them money. Prozac's great. Cognitive behavioral therapy is good too. And as I suggested, the eclectic view, which is hopefully what you are getting if you're suffering from depression, is a little bit of psychotherapy and some drug therapy. And that's where you get the best outcomes for treating depression. As I suggested, some doctors favor the drug-free method, though it is more difficult, time-consuming, expensive, and it requires the patient work too. But most importantly, the insurance company is going to pay for the cheaper therapy. Okay. So, with bipolar disorder, we give you the drug that sort of slows down the rapidly cycling emotions, and then we add an antidepressant or an antipsychotic. For people with depression, we know it's related somehow or another to serotonin function, so we give them drugs that magnify their serotonin function. For people with schizophrenia, we know that people suffering from schizophrenia, we give them drugs that decrease the effectiveness of the dopamine in their brain, that impair the functioning of the dopamine in their brain. And this causes their psychological delusions and hallucinations to get better. Now, if you'll look over here, I've got some charts talking about this and some detail I'd like to work through real quick. Now, if you remember when I talked about schizophrenia, I suggested to you you can characterize the symptoms different way. There are what we call positive symptoms of schizophrenia and what we call negative symptoms of schizophrenia. The positive symptoms are the things that are added into you that we don't want. The addition of delusions, the addition of hallucinations, the addition of this disorganization in our thinking. On the other hand, schizophrenia also takes some things away. It takes away your motivation. It takes away your emotions and causes your emotions to flatten. It takes away your excitement. And so we have these negative symptoms and we have these positive symptoms. Now, if you look over here in the top chart, if you look at the top chart, what you're going to see is the first generation of antipsychotics that were created, Thorazine, Haldol, and some of these other antipsychotics were really good at making the positive symptoms go away, but they didn't really affect the lethargy and the lack of emotional functioning of your psychotic patients. So if you'll notice over here, the yellow line represents the negative symptoms, and you'll see with the typical antipsychotic drug, what you're going to see is that the positive symptoms get much better, right? Well, I take that back, not much better, a little bit better. But you'll notice, so that's the yellow line. So look at the yellow lines. Those are your conventional antipsychotic drugs. You'll see that they work a little bit on your positive symptoms, but they didn't really affect the negative symptoms at all. So they weren't that effective. More importantly, they had a side effect that tended to occur with its usage. And this side effect is known as tardive dyskinesia. If you look carefully on the drug commercials you see on TV for treating psychological disorders, when they talk about antipsychotics, one of the things they're going to mention at the end of the commercial is these side effects. So tardive dyskinesia is this involuntary ticking that tends to happen a lot in the facial feature, these lip smacking, these facial tics. And the crazy thing is, once you develop tardive dyskinesia, stopping the medication doesn't necessarily guarantee that the tardive dyskinesia is going to go away, right? So here's the deal. We have these conventional antipsychotic drugs in the yellow lines up here. And what you'll see is the first generation of antipsychotic drugs treated your symptoms a little bit, not a ton, but they made some of them go away, but they didn't do anything about the emotional apathy that people had. And it had this side effect. Now, what we now use today, what's more common today, are the use of what we call atypical antipsychotics. These things like Risperidol, Seroquel, I don't know if any of you have heard of Depakote. These are antipsychotic drugs that are used. And these atypical antipsychotic drugs are much better than the older generation of antipsychotic drugs. And if you look at the green lines over here, what you'll notice is that over 6 weeks, the atypical antipsychotic shows a much steeper decrease in the psychotic symptoms, the delusions and hallucinations experienced by people with schizophrenia. If you look in the bottom chart, you'll notice that the negative symptoms, they actually seem to impact the negative symptoms. So they help the mood come back. They help the energy come back in the schizophrenic patients. And they are also less likely to result in tardive dyskinesia. Now, they still may end up causing tardive dyskinesia, but they're much less likely. So what you're going to see, we have two different kinds of antipsychotic drugs, and you can see how we've evolved into antipsychotic drugs that give us a better behavioral outcome and a lower incidence of side effects. So those are your antipsychotic drugs. Now, this is just for your interest. This is a chart that your book looks at. But what it's going to do is going to tell you all the different drugs that we have, the treatments provided, what types of drugs and what kind of side effects you might see in these drugs, and then what the brand names are. You notice we've got drugs to treat anxiety, drugs to treat depression, drugs to stabilize your mood, drugs to make your psychotic symptoms go away. And then we have stimulants, which actually, this is crazy, these stimulants are a lot of times used for people with ADHD. Now, why would you give a person with ADHD a stimulant? Doesn't that make them even more out of control? No. The crazy thing about these stimulants is these stimulants stimulate the part of your brain that slows you down. What? So I'm going to get a drug, it's going to stimulate me, and that slows me down in a sense? Yeah, sort of. So ADHD drugs like Ritalin or Adderall, you take them and they make the frontal lobe more active. And that's the part of your brain that causes you to control yourself and focus. And so these drugs make the part of your brain that focuses more active. And so we've got all these different kinds of drugs: Valium, Xanax, and Ativan for anxiety. You've got Prozac, Paxil, and Zoloft for depression. We've got lithium for bipolar disorder. We've got Thorazine, Haldol, Risperidol, and Seroquel for your antipsychotic drugs. And then we've got Ritalin and Adderall. How many of you folks have heard of these drugs? Do any of these drug names sound familiar to you? And by the way, I want to take this moment to say good morning to the crafty table. Thanks for showing up. I was in the middle of running my mouth. I saw you when you came in, and you're late to the club notice, but I was just talking too much. You doing okay? So, yeah, let me know. Do any of you have any experience with these drugs that you want to talk about? Adderall for you. Good deal, Julia. Fantastic. You know, I often heard that Adderall came around after I grew up. We didn't really, I don't remember ever hearing the word Adderall or Ritalin when I was a kid in middle school or high school. But I know that it's become popular. I've heard that people actually, I take this back. I have to make a confession. I was the assistant coach on the baseball team at Wake Tech for several years back. And one of the things I noticed, and it absolutely just drove me nuts, was some of the ball players 5-7 years ago used to take Adderall even though they didn't have a prescription, because they said it helped them focus and study better. How many of you have ever heard of people taking Adderall or Ritalin even though they didn't have a diagnosis? Did any of you ever see people selling or using these ADHD drugs for entertainment or fun? Adderall gives you depression. Really, Julia? That's interesting. The crafty table has heard of some of these as well. Okay. There are a whole class of these drugs. The crazy thing is, we know they cause behavioral effects, but we don't really know. And I swear to God, and if you talk to a clinical psychologist, they'll yell at you about me and they'll tell me that I'm wrong and I'm a liar. But here's the deal: we really don't know exactly where in the brain these neurotransmitters work to cause the desired effect. We don't 100% understand the chemical mechanism that goes on. All we know is that these drugs seem to have the impact that is desirable for us. So, Juliet can't even take Adderall because of the depression. I've never heard that. That's an interesting observation, Juliet. And some people take it for pain. Does Adderall for pain? I've never heard that as well either. Juliet, do they take it on the recommendation of a doctor, or is that something that just happens, that just people do on their own? Adderall helps them to control pain. Really? Is that a doctor telling them to do that, or is that just a person using it and saying that's the desired effect? I'm not downing those people, because I'm going to be quite honest, the doctors don't know much more than that. Oh, they just do it on their own. Well, honestly, it causes the right behavioral effect. I hate to say it, but that's not even really less sophisticated than the logic that is used by scientists to discover drug treatments for psychotherapy. So if it works for them, I mean, I can't say they should. I'm not an expert one way or the other, but it doesn't sound to me like it's scientifically. I mean, that reason for taking it isn't any less serious than the reasons that doctors have decided to prescribe these drugs for us. Now, there are other biological therapies aside from drug therapies, and whether or not you take a drug to treat a psychological disorder is up to you and your private consulting doctor. I will tell you, however, like I said, these drugs that you take will not be a magic bullet to solve all of your psychological problems. Some of you will experience relief partially. Some of you may experience complete relief, but as a general rule, I don't think these drugs necessarily work perfectly to cure the conditions that they are supposed to cure. Think about that. When we give people diabetes drugs, the diabetes clears the problem up. When we give people cholesterol drugs, it completely clears the cholesterol problem up. And yet, when we give people antipsychotics or we give them psychotropic medication for psychological disorders, they don't always completely clear the problem up. So drug therapies capitalize on our understanding of neurotransmitter functioning, which is one major mechanism. If you remember from chapter 2, I said your brain, your neurons secrete neurotransmitters. So one big functional mechanism in the brain is the secretion of these chemicals. And so drug therapies take advantage of this big root of neurological functioning to treat psychological disorders. Second way that your brain communicates, your brain generates electricity. And we've talked about this a couple of different times. We talked about it in chapter 2, the action potential. And then in chapter 3, when we were talking about sleep and the different types of electrical activity that your brain generates as you move through the stages of sleep. So your brain generates electrical activity. And so what some psychologists have figured out is that some psychological disorders seem to be related to, can be improved by using electrical stimulation. Okay, so deep brain stimulation. So let's talk briefly about that. Electricity. And so there are lots of different ways to do this. And there, your book's going to show 3 different kinds of therapies based on this idea of electrical functioning in the brain. Electroconvulsive therapy, transcranial magnetic stimulation, and deep brain stimulation. All right. Now, electroconvulsive therapy is kind of controversial, and it was actually used at the turn of the 20th century, in the early 1900s. It was actually used as a means of behavioral control for psychotic patients before we had the antipsychotic drugs. And electroconvulsive therapy, and it also there are several different movie clips, cultural memes that have sort of given electroconvulsive therapy a bad name. Neurofeedback is not electrotherapy, but I can't speak in detail about neurofeedback, but it's different from the electroconvulsive therapy. In the electrical convulsive therapy, what we do is we use electricity to sort of put you into a seizure. So we cause a seizure, and then when people come up out of this seizure, they tend to feel better. The depression symptoms sometimes go away. I say sometimes, it's not a guarantee, but electroconvulsive therapy is used to treat people who are suffering from severe depression that doesn't respond to drug therapy. You'll look down here, you'll notice a bunch of people standing around holding this person. Oh, wait a minute, nope, actually I take that back, wrong picture. That's psychosurgery. If you look over on the far left corner, you'll notice this lady has a rubber thing in her mouth to keep her from biting her tongue when she has the seizure. And they've got her strapped down, and people are going to hold her. And what they're going to do is they're going to give her a brief pulse of electricity. It's going to send her into a short seizure, and hopefully when she wakes up, her depressive symptoms will be better. Now, one of the reasons that electroconvulsive therapy is so controversial is because in the old days, it used to cause such a person to flail about and shake. It was a really, if you will, it was, I forget, I don't know what the word is, but it was really shocking what would happen when you give somebody that shock. They'd just jerk around. And they used to have a bunch of people that would hold you down on the gurney to keep you from thrashing about. And some people during these seizures would actually injure themselves. so they would actually throw a back out of place or injure or in some other way hurt themselves. What they do right now is they give you a muscle relaxer before they do the electroconvulsive therapy so that people don't thrash about as hard when they have their seizure. And so electroconvulsive therapy is useful for severe depression. Some people think it works. Other people think it is a barbaric form of treatment that harks back to the beginning of clinical psychology. And I honestly, as your teacher, can't tell you which of those viewpoints is correct. I will tell you that some people have found relief with the use of electroconvulsive therapy. Now, less shocking than that, because it doesn't make you jerk around, is this idea of transcranial magnetic stimulation. So they take these powerful magnets that have electrical waves, that have the electrical forces, and you can put this over parts of the brain. Now, we talked about this in chapter 2, and one of the neat things with transcranial magnetic stimulation, TMS, it's used in research methods as a research tool too. Because TMS, when you use the TMS and put it over a specific area of the brain and turn the machine on, it cuts that part of the brain off for just a moment. It's like a temporary brain lesion, and it causes people to lose the function of whatever that brain area caused for just a moment while the machine is on. And then when you turn the machine off, the brain area comes back to life, and the function comes back. Researchers have found that the use of these TMS stimulators that interrupt neural activity also help people suffering from depression that doesn't respond to medicine. Again, it's an experiment. We're trying to see what works. And that doesn't sound to me quite as confident and as knowledgeable as we should be. It represents an incomplete knowledge. Now, the third thing that we use is this idea of deep brain stimulation. Now, this is kind of weird because it involves chemical functioning and electrical functioning. People who suffer from Parkinson's, they do because an area deep in their brain, the substantia nigra, starts dying. This area is where dopamine is produced in their brain. And what happens is dopamine, since the dopamine producing area of their brain dies, this dopamine isn't secreted to activate parts of their brain that control people's shaking behaviors. So you have this structure in your brain. Oh my goodness, I can't believe it's going to pop right out of my head. Oh my goodness, not the cingulate cortex. I forget those brain structures down in the middle of your brain around your thalamus. For dadgummit, I can't remember that name. But there's this area deep down in your brain where dopamine is released, and that causes your motor movements to become smooth. It's a part of your brain that keeps one part of your body from not moving while you're trying to move the other part of your brain. And so what happens is this part of the brain isn't receiving enough dopamine, so it's not active enough. And so what they do is they take a electrical wire and stick a wire into this area of the brain. And since it's not getting enough dopamine, what they do is they set this electrical pacemaker to stimulate that area of the brain. And that stimulation of the area of the brain takes the place of the dopamine that's not being reduced. In deep brain stimulation, the pulsing associated with deep brain stimulation causes the Parkinson's disease, the Parkinson's symptoms to go away almost immediately. I've actually got a video of it. It's used to treat Tourette's syndrome too. It's used to treat obsessive compulsive behavior as well. And it's also used to treat dystonia, which is this weird disorder that makes people's muscles contract and bends and contorts them into weird positions. All of these are disorders that occur when body parts move around when you don't want them to. So Parkinson's, people shake and have trouble walking. Tourette's, People yell out and say impulsive things that they can't control. In OCD, people have thoughts and behaviors that they can't control. In dystonia, your muscles flex and contort in ways and you can't control them. And so the point of this deep brain stimulation is to go down and stimulate that middle part of the brain around the thalamus that's not getting enough dopamine to do its job. And the crazy thing with the deep brain stimulation is it actually makes the shaking symptoms go away almost immediately. It's like turning a light switch on and off. If anybody's interested in seeing this, I highly suggest you Google deep brain stimulation and Parkinson's. And there are tons of demonstrations that people have put on YouTube where they turn their deep brain stimulation on and off, and you can watch the symptoms right there on YouTube come on and then go away. It's absolutely crazy. It's absolutely crazy. And so these are the different methods by which we can capitalize on the biology of the brain. Now, I do want to mention psychosurgery too. We can also go in and cut and remove and change parts of the brain. Now, what you see below me here is a very barbaric form of therapeutic treatment that is no longer used anymore. It's called a pre-frontal lobotomy. This was developed early in the 20th century before we had antipsychotic medication. And the reason that this treatment became popular was because it actually did cause schizophrenic people's symptoms to get a little bit better. What they would do is they would use ECT, Electroconvulsive Therapy, to stun you and knock you out. So they'd shock you, and when they shocked you, you'd sort of lose consciousness for a couple of minutes. They would then take a long, thin blade. The first ones were actually ice picks, real thin ice picks. And what the doctor would do, you see the doctor here is holding a hammer, and the thing that you can't quite see because the picture is very small is he's holding an ice pick. And what they would do is they would take that ice pick and they would slide it up underneath your eyeball, underneath your eyelid, between your eyeball and your eyelid, and they would stick, and there's a little bone, an orbital bone, and they would take a hammer and knock it through that bone and stick this ice pick up into your frontal lobe and on both eyes, and they would wiggle it back and forth, and they would sever your frontal lobe from the rest of your brain. Okay, this was called a pre-frontal lobotomy. The crazy thing was they didn't do this under general surgery, and it didn't take longer than about 2 minutes to do. They would knock you out with the ECT. They would slide these ice picks underneath your eyelids, knock them through your orbital bone, and basically just damage your frontal lobe. And this therapy actually made people's hallucinations and delusions go away. Of course, it absolutely disrupted tons of other behaviors and made the person amotivational. And there was a time in the 1950s and 60s when lots of people were being given lobotomies as a way to control their schizophrenia. Now, this practice is no longer used, but it did represent the first attempt at using surgery to affect people's psychological disorders. Really, the only psychosurgery that I'm going to talk about today is what we call a commissurotomy. Now, the corpus callosum is the part of your brain. It's the band of axons that connects the left half of your brain with the right half of your brain. People who have seizures have uncontrolled spasms of electrical activity that just spread over their brain. It's kind of like a short circuit of a brain, if you will. And people who suffer from seizures, sometimes, I don't know if you've ever seen somebody have a grand mal seizure, but they'll fall onto the ground, their eyes will roll back in their head, and they'll shake and they'll shudder. People who have seizures that don't get better, don't respond to medication, one of the things you can do is you can go into the brain and you can slice that corpus callosum in half and separate the left half of the brain from the right half of the brain. Now, we talked about this in chapter 3 when we were talking about what the left half of the brain and the right half of the brain does. And if you completely separate the halves of the brain, there are some side effects associated with it. What they do now with the commiserotomy is they cut 2/3 of the corpus callosum in half, and they leave, I think it's a part of the corpus callosum called the spleen right at the back. They leave that. And what happens is you get the benefits of the anti-seizure, effect without the side effects that go with it. All right. So, along with giving you drug therapy to help you help your psychological disorders, we can also do surgery on your brain. We can use electricity, or we can use electricity to alter the functioning of your brain. And so these are the different biological treatments that capitalize on our understanding of how the biology of the brain works. Okay? Now, one of the things that you do need to keep in mind, we don't know 100% how the biology of the brain is related to behavior and thoughts and understanding. We don't know how an elephant, when memories are stored in biological matter. We really don't know that. We don't understand all the connections that happen between the different areas of the brain. We have an incomplete understanding of brain anatomy, chemistry, and functioning. So these drugs, these biological treatments that we used are based on that lack of complete knowledge. And so I would tell you that psychology, psychotherapy, clinical psychology is still a practice in development. It's not a pseudoscience, as that critic I heard on Monday said. It's not a pseudoscience, but it's a science in its infancy that still needs more knowledge before we can truly understand how to treat brain disorders. And so that's something you need to keep in mind as you go into the world and you are a customer who may or may not use psychological services. Just keep in mind that we don't know 100% about what's going on, and you have to be careful when you use these very powerful biological therapies such as drug therapy or electrical therapy. All right, it's 9:52. I've taken too much time already, and I do apologize for that. But I just, this is the last lecture. Can you believe that? We are done. And so tomorrow morning at 9 a.m. we'll have a review. One of the things that I wanted to remind you is don't forget to do your course evaluation that's due tonight at 11:59 p.m. And email me that confirmation or upload it to this week's discussion board. I'm going to go ahead and log off now. It has been great meeting each and every one of you. Juliet, Lewis, I don't know if the Dominican Republic is in the house today, but it's been absolutely seeing each and every one of you this semester. You've been great students, and I wish you the best of luck in your future schooling. Don't forget, review tomorrow morning at 9 a.m. for the final exam, and you have all weekend to do your final exam. And not all weekend to do your homework, but remember we have homework this week as well as a final exam. Homework's due on Friday, final exam is due on Sunday. Now, this due date for the final exam is a drop dead date. I am posting grades Monday morning at 8 a.m., so you must complete your exam this weekend, okay? All right, folks, take care, have a great day, and I will see you tomorrow morning for the review session. Bye.